My name's Hannah. I'm one of the cardiologists from Evelina, and this talks about the collapsed neonate and looking at cardiac causes of a collapse in the neonate. So in terms of the incidence, just under 1 in 100 children have congenital heart disease, and around a quarter of these will have a critical heart defect. Although antenatal diagnosis is improving, still many will still present postnatally. The diagnosis group, so I'm just trying to move that out of the way of my slides. The diagnosis group can often be made clinically without echocardiography, and which can allow early targeted management prior to moving on to anything else. The other thing that I often just mention in these talks is really only those that can echo should echo. We have seen in the past the wrong diagnosis driving the wrong management with potentially catastrophic results. So that doesn't mean that you have to be a cardiologist, but you've got to be confident with what you're doing, your interpretation of the images, and that usually means have done some specific training either in a paediatric cardiology job or as a PEC or as a neonatologist with expertise as well. The other mainstay is close liaison with a paediatric cardiac centre as soon as you think it could be cardiac, and then they will be able to help you and advise. So in terms of the outline of this talk, I'm just going to talk briefly about the changing circulations, causes of cyanosis, and then look at some clinical cases, looking at history, examination, oximetry and blood pressure, chest x-ray, ECG, and then some management, as well as cardiomyopathies and arrhythmias briefly. So in terms of changing circulations, in the womb, the lungs are bypassed with the PFO and the PDA, and there is high pulmonary vascular resistance. As there is no air in the lungs are not used, and the placenta is the form of oxygenation, and the placenta therefore supports the circulation. The PDA usually closes over the first few days of life, and that's where you might see duct-dependent pulmonary and duct-dependent systemic circulations presenting. The PVR generally falls over the first 4 to 6 weeks of life, and that's when you will see children with large left to right shunts starting to present. And the PFO generally closes over the first year of life, but actually a quarter of adults will still have a small atrial communication. However, a restrictive atrial communication in the newborn may be absolutely critical in mixing dependent lesions. And the timing of the presentation therefore depends on the problem. So just first off, just start thinking about why a patient might be blue. So obviously the most likely thing is that there's a respiratory problem, and in all neonates that's probably still the most likely issue. But if we're going to concentrate on the cardiology, there are 3 areas where I usually divide things up into. The first is inadequate mixing. So this is patients, such as patients with transposition of the great arteries. So they are reliant of mixing of the blood to have some oxygenation of the blood, as without mixing they will just have 2 parallel circulations. And that mixing occurs at atrial level and ductal level, and actually the majority of mixing actually occurs at atrial level. And examples of this are babies that are born with transposition with an intact or highly restrictive atrial septum that may be born with SATs in the 20s or 30s despite having a widely patent duct. They undergo a septostomy and their SATs come up to the 70s and 80s prior to surgery. The next group is that there is inadequate pulmonary blood flow. So this is your sort of critical pulmonary stenosis, pulmonary atresia, extreme tetralogy of Fallows, and as the duct closes, you don't get enough blood going to the lungs, and therefore the patient desaturates. The final group is those with obligatory mixing, and that is, for example, the TAPVD group. And in these patients, they're dependent on having their ASD or PFO patent to allow mixing of the blood. So, for example, in TAPVD, all the blood is returning to the right atrium, and so to fill the left heart, the blood must go across the atrial communication. So these are the 3 broad areas to think about when a patient is blue, and then that can start help you think which direction you might be going in. So first case, 7-day-old baby boy, term, prolonged rupture of membranes, 48 hours of antibiotics and home, presents with reduced feeding over the last 24 hours, breathless recession, the femorals are absent, the brachials are present, there's a soft systolic murmur, 3 centimetres of hepatomegaly, the right arm SATs are 96 and the left leg SATs are 95. So these are all actual sort of real cases. And obviously, usually I do this more interactively for people to guess the questions, but I think it's a bit difficult to do over video conferencing. But I think a lot of people have got the diagnosis from that story, particularly with that second bullet point down. So coarctation of the aorta is a narrowing of the aorta, and that's usually in the upper part of the descending aorta in the region of where the duct is. And on this diagram, you can see a narrowing just after the duct inserts. And this is a patient who has a nice big ascending aorta, some narrowing of the transverse arch, and then it really does pinch down, and you've just got this little tiny jet of flow getting through that narrowed area there. So severe coarctation is duct-dependent supply distal to the coarctation. So the left arm, the kidneys, the liver, and the gut. A milder coarctation, however, may not be duct-dependent and may present much later. These babies may well be well at birth, and they may well also have a normal baby check. And these are the children that you will miss potentially on the saturation screening, as they may not necessarily have an upper limb, lower limb differential. And if the duct is shut, but it's not critical, you may have normal saturations and only very subtle differences in the upper and lower limb pulses. This is another group where it's absolutely essential that when you feel the brachials, you feel the brachials and femorals at the same time, looking for a difference between the two. And these babies will often present with reduced feeding, breathlessness, lethargy, progressing to hemodynamic collapse and shock. And the timing of that will depend on the nature of the coarctation. So some neonates will present with hemodynamic collapse as the duct closes very early on. Others may present with ventricular dysfunction, having had a tighter coarctation for a longer period of time. In terms of examination, there'll be respiratory distress with tachypnea. The child may be tachycardic with reduced perfusion and absent or weak femorals when compared to the right brachial. And it's really important to compare to the brachial, as I've been caught out by this before. And there may or may not be a murmur in a neonate. They may have hepatomegaly, and they may have potentially distended abdomen, as some can get neck due to the reduced gut perfusion. When you're looking at oximetry and the blood pressure, this is a schematic which assumes that the coarctation is after the left subclavian artery, and in this first picture, this is where the duct is open. So if you have a severe coarctation, you may well get SATs in the arms which are higher than SATs in the feet, and obviously this is the same picture that you might get in PPHN. And as the duct is open, you may not actually get a blood pressure differential. So this is a kind of picture that could go for PPHN or could go for something like an interruption or a tight coarctation with a duct that is patent. As the duct starts to close, you start noticing the blood pressure decreasing and the saturations increasing. And then once the duct has closed, you will not have right to left flow across it, and therefore the SATs in the feet and the arms may well be normal, but you'll have a blood pressure differential. So it's really important to learn that pattern, because you could be encountering children anywhere along that pathway. The left arm can be very difficult to interpret, as the left arm can be pericoarctation. So if in doubt, the safest thing is to do a right arm and a leg. There is no reason why the legs should be any different. So if you've got a really squirming baby, just one leg and a right arm blood pressure is often a good place to start. In terms of the chest x-ray, this is my sort of generic newborn baby chest x-ray. There may not be much to see on the chest x-ray. It could well be that as the child becomes more unwell, you start getting pulmonary plethora, you might get cardiomegaly, but often the neonates that present relatively early don't have much in terms of impressive chest x-ray findings. And pretty much the same for the ECG. You will usually have a pretty normal looking ECG, as the placenta has been supporting the circulation and the duct has been open in utero, so there is little reason why this heart would be struggling at this stage. So in summary, coarctation presents as the duct closes. You get reduced perfusion, particularly to the lower limbs and therefore the gut and the kidneys, absent or weak femoral pulses, an upper limb, lower limb gradient of more than 20. If the duct is open, the SATs may be lower in the feet, but if the pulmonary pressures have dropped, you may also get left to right flow, even in the presence of coarctation, so that's not always a given. They may become breathless as they get pulmonary congestion secondary to high LA pressure from high LV end diastolic pressure, and it's important to try and intercede prior to hemodynamic collapse and shock. So that's a little bit of background, but what would you do? So of course, as with any sick child, you would start with getting help in ABC. And if you really think this is coarctation of the aorta and this is a diagnosis you can make reasonably well clinically, then you should be starting Prostin and arranging transfer to a cardiac centre. Even in some babies who may be a bit older and you won't necessarily be able to reopen the duct, you may well be able to relax the ductal tissue enough in the aorta to allow a bit more blood flow. Inotropes are of limited use as they generally just increase the pump against fixed obstruction. And then when the patient arrives at the cardiac centre, they'll have a full assessment of the arch to decide whether it needs a repair from the front or from the side, and then looking for any associated abnormalities. So, next case, a 5-day-old baby boy, 4 kilos, feeding well, and he's referred as the midwife felt he looked jaundiced. So on examination, the femorals are palpable, there's no murmur audibles, the right arm sats are 35%, and the leg sats are 76%. So again, that particular pattern of saturations, so have a think about that, but that's a particular pattern of saturations that it's important to be able to recognise. So this patient has transposition of the great arteries. So here the pulmonary artery arises from the left ventricle and the aorta from the right ventricle. And in the echo picture there, this is just a sweep that shows there's the aorta coming from the right ventricle and there's the pulmonary artery from the left ventricle. And we can tell what's an aorta and what's a pulmonary artery because the pulmonary artery bifurcates and an aorta gives rise to the coronary arteries. So if the atrial communication is adequate, then the saturations may start to fall just as the duct closes. And these children can often be very blue, but actually quite well. And this particular baby was sat on PICU with everybody staring at the baby, breastfeeding, and then had an arterial switch the following day. If the atrial communication is not adequate, there may be profound cyanosis and therefore acidosis despite a widely patent PDA. And these are the babies that present immediately after birth, sometimes with respiratory distress and profound cyanosis. But they will often have a more normal looking chest x-ray and therefore be a bit easier to differentiate from PPHN and meconium aspiration, etc. So the baby may well be well and blue, but they could also be shocked and blue. Perfusion may be good, but they could be shocked if they are profoundly cyanotic and acidotic. And they may or may not have a murmur depending on any associated lesions or if the PDA is present. So this is the classic picture which I talked about, which is called the reverse differential saturations. And here the right arm saturations are lower than the rest of the saturations. And this is because the first branch of the head and neck vessels is to the right arm. And therefore the saturations in the right arm reflects what's leaving the right ventricle. And therefore that's the blue blood. And then postductally you will have mixing. And so the saturations will also be higher. So you will see this classic reverse differential pattern. Chest x-ray, you have this whole kind of egg on a stick thing. I'm not that convinced on neonatal x-rays. If you look at some of the adults who've had a mustard or a Sennings, as the older operation for this, they do definitely have a very narrow pedicle, narrow mediastinum, but I'm not totally sure that that's truly reflected. And I think if you saw this x-ray in a child who wasn't blue, you probably wouldn't think twice. And again, the ECG will be unlikely to show any abnormalities in this neonatal period. So in summary, the presentation of TGA can be variable. They can be well and progressively cyanosed as the PDA closes, and this is a more common presentation, but probably about once a year we get a child presenting profoundly shocked and blue after birth. And really, unless that child can be got to a cardiac centre for intervention immediately, the patient will die. The murmur may not be present, but will depend on associated lesions. The key thing is this reverse differential saturation, and the chest x-ray is probably unlikely to have that so-called characteristic appearance. So in terms of management, ABC, get help, start Prostin, transfer to a cardiac centre. The other thing that can be a particular confounder is PPHN can coexist. And then you can get yourself in all types of confusion by trying to describe right to left flow at ductal level, and you end up talking about blue and red flow of blood, and that's usually the easiest way to think about it. Inotropes and resuscitation may be required if the child is profoundly shocked, but really the only thing that you can do is improve the saturations. And the picture that you can see on the echo here is the balloon being inflated and then pulled back across the atrial septum, or opening up the atrial communication. And patients may well need an urgent balloon septostomy, which may be life-saving prior to their arterial switch. So next case, an 8-day-old baby, 36 plus 5, 3 days, IV fluids and established feeds and went home, not feeding as well the last few days, has an ejection systolic murmur at the upper left sternal edge, the femorals are palpable, the chest is clear, and the saturations all over are in the sort of lowish 70s. And so this is a patient who's presenting blue reasonably well and has a murmur. So start thinking again. Obviously, we're going through a list of diagnoses, so by exclusion, you can take 2 of them off at the moment. And this is a patient who's presenting with critical right heart obstruction. And from this, it's very difficult to know whether this is a patient with tetralogy of Fallot or pulmonary stenosis, but it's probably not pulmonary atresia because you've got a murmur. Because if you haven't got any flow across the pulmonary valve, then you're not going to get a murmur from it. Now, the echo picture here is one of the ones that it's very easy to get caught out. And this is an echo picture showing the aortic valve in the middle. This is the left atrium, right ventricle, and this is the pulmonary artery, and this is the pulmonary valve. And on first look, you would say, well, this is a good sized vessel, about the same size as the aorta, and there's clearly a valve there that's moving. But if you actually look very closely, this valve is moving, but it is not opening. And this is membranous pulmonary atresia. And this is where one of the situations that you can get caught out if you're doing an echo and you see this and you put colour on and you see flow there, you may be fooled into thinking that that valve is patent. Because what can happen is the blood can come down the duct, hit the valve and bounce off and look like forward flow across the valve. So the history is often a baby who's well at birth. As the duct begins to close, the baby becomes more blue as they get less and less pulmonary blood flow. And again, they may well remain reasonably well, but will be becoming more blue. And again, with increasing cyanosis, you get increasing acidosis. So on examination, they may well be reasonably normal, but cyanosed. Critical pulmonary stenosis or tetralogy will have a loud murmur, but pulmonary atresia may not have a murmur. So in terms of the oximetry, all the saturations are low regardless of whether the duct is there or not, and the blood pressures will be okay. The chest x-ray, now this is a chest x-ray that I've put in. This is obviously not a neonate, it's a slightly older child, and this child had a complex anatomy, tricuspid atresia and pulmonary stenosis, and his blood was fed through his VSD to his pulmonary artery, and his VSD became restrictive. So he presented at about, I think it was about 6 months of age, with saturations that were in the 20s to 30s. And he was pretty well with it, but he'd got very restricted pulmonary blood flow. And he ended up having an emergency BT shunt on PICU because there was no theatre space. And this just shows his chest x-ray at the time when his saturations were sort of 30s. And really, it's very difficult to say that this is an oligemic looking chest x-ray. It just looks like an x-ray where you would say no collapse consolidation. So you may see oligemia, but equally you may not necessarily see particularly black lung fields. So the ECG, now this starts to be where you can see some abnormalities on the ECG. So if you have significant right outflow obstruction and you have right ventricular hypertrophy, then you will have a right dominant ECG. Now, unfortunately, all neonates will have a right dominant ECG, so that might not be helpful. However, if you have a hypoplastic right ventricle, so say where you've got very severe pulmonary or tricuspid stenosis or atresia, you will have a left dominant ECG, which is always abnormal in the neonate, and this may be giving you a pointer. You may also have tall peaked P waves, so the P pulmonale reflecting right atrial dilatation, so that can also give you a clue as well. So in summary, these kids may be quite well and blue. All the saturations are reduced with good pulses and blood pressure. The chest x-ray may look oligemic. You may see right dominance on an ECG, although this is normal, but if you see left dominance on an ECG, this is always abnormal. So what would you do? So the answer to virtually all of these questions are ABC, get help, commence Prostin, and then transfer to a cardiac centre. And the management thereafter will depend exactly on what the underlying diagnosis is, but even some of these children with pulmonary atresia can have their valve opened up by catheter. So case number 4, a 4-day-old baby boy born
Anna,
at
for your Anna, there is a little chat window if you press a button. And actually, on this case, when you get to the question points, we can probably force some people to give you some answers if you want.
Okay.
We could try it.
Okay,
The chat window doesn't show automatically, but if you see there's a little speech bubble and press it, you'll see. And some people can talk as well, but we'll force people to give you some responses.
Okay, fine. No, that's fine. No, I've managed to open it up so it doesn't like crowd my slides, so I can't read them as well. So that's quite good. And I think just if you are answering, make sure that you've selected it to send to everybody, because otherwise, I think I can only see it if it's that rather than the private ones, or there seems to be some settings. I think I get some messages. Okay, so this one, 4-day-old baby boy, born at term, meconing at delivery, but observed and then discharged. The maternal uncle has a bicuspid aortic valve, and there's a 24-hour history of sweatiness. On examination, he presents poorly perfused, brachials and femorals are felt, there's significant respiratory distress. He's got 4 centimetres hepatomegaly, the right arm and leg saturations are both about 92%, and he has a 3 out of 6 ejection systolic murmur at the upper right sternal edge. So what do people think could be going on here? So, there we go. We've got a few suggestions coming in. Yep, so I think people seem to be relatively unified, and I think you've got the family history, and you've got the murmur that's at the upper right sternal edge, and you've got all your pulses being reduced. So let's go on. So this is a patient presenting with critical left heart obstruction, and you're right, given the presence of the murmur, this is likely to be AS and likely to be critical AS given the age the baby's presenting and how sick the baby is presenting. So critical left heart obstruction is a spectrum from aortic stenosis through to hyperplastic left heart syndrome, and the diagram and the echo show a patient with hyperplastic left heart syndrome. So you've got here normal concordant connections, but a small mitral valve, a small left ventricle, and a diminutive ascending aorta with coarctation. And then the echocardiogram picture here, you could have a big right atrium, a big right ventricle, and this here is what's left of the left ventricle and the left atrium. So this baby is somewhere on the left heart obstruction spectrum. So the presentation is relatively similar to coarctation, and that these babies are usually pretty well, and then as their PDA closes, they present with reduced feeding, breathlessness, and then hemodynamic collapse. So of course here, if you have obstruction coming out of the heart, then you've got obstruction to blood flow everywhere. So these children, in addition to distal perfusion issues, so liver dysfunction, renal dysfunction, gut dysfunction, may also present with seizures and signs of global hypoxia and global collapse. So on examination, baby's got respiratory distress, tachypnea. They may well be pale and just have reduced global perfusion or shock and hepatomegaly. And these kids, these are the ones, particularly that usually get a good dose of antibiotics as well. And I think that's never the wrong thing to do, because of course cardiac kids may also have sepsis and be presenting with a septic element, and that may be what's actually bringing them in. An example that we had was an 8-day-old that came in collapsed and was found to have situs inversus and an AVSD, which obviously you wouldn't expect to present at day 8 of life, and then his culture subsequently grew group B strep. So it is important to remember that things can coexist. So in critical left heart obstruction, all the blood pressures are going to be reduced because you have an obstruction to flow of the blood getting out of the heart. Now, if you have a wide open duct, then you actually may have better blood pressures because the body is being supplied by the duct. The saturations in the single ventricle conditions, effectively you have common mixing, and the saturations immediately after birth are often in the sort of high 80s, low 90s. And then as the PVR falls, the pulmonary blood flow increases, the systemic blood flow decreases, and the saturations rise and maybe in the high 90s. So in terms of the chest x-ray, you may start to see some changes on a chest x-ray, particularly if the baby's presenting quite clapped out. So they may have an enlarged heart, and they may have relatively plethoric looking lung fields. And again, onto the ECG. And again, a bit like the critical right heart obstruction, if you've got marked left ventricular hypertrophy because you've got significant aortic stenosis, then you are going to have a left dominant ECG, which is always abnormal. However, if the left ventricle is hyperplastic, then you will have a right dominant ECG, and in hyperplastic left heart syndrome, the ECG is often normal for a neonate. These patients may have bifid P waves for P mitrale, so left atrial dilatation, but if they don't have dilated left atrium, then that may not be present. So in summary of the presentation, the babies are often unwell with respiratory distress, reduced perfusion, multi-organ dysfunction. All the pulses are usually reduced. The saturations may be normal or just mildly reduced. The chest X-ray may well look plethoric, and you may see right dominance on an ECG if a hyperplastic left heart variant, or you could see left dominance, which is always abnormal if there is significant left ventricular hypertrophy. So what would you do in this situation? Yeah, exactly. I think that's the key thing for all of this is get help, ABC, and start prostin. Now, the main thing that I always say, if the minute you think it could well be cardiac, is start getting people drawing up the prostin. Prostin is a real nightmare to draw up. It's not, particularly if you work in a DGH, you might see 1 or 2 cardiac babies a year, and it's really quite challenging to get it drawn up. And I remember as an SHO a few times trying to draw it up myself, and it takes forever to do. So if you think you need prostin, start getting it drawn up. If you don't end up needing it, you can always chuck it away. So again, ABC, start prostin, transfer to a cardiac centre, and then all the left heart structures will be assessed to see whether this is a patient that will be able to have a biventricular repair or need to go down a Fontan pathway. So I've just put a little bit in here about the concept of overcirculation. So this is particularly referring to children preoperatively who have a single ventricle condition or after a procedure such as the Norwood or an arterial shunt. So effectively, you have pulmonary circulation and a systemic circulation which are precariously balanced. Effectively, you have one output that has 2 choices. It can send blood to the lungs, or it can send blood to the body, or it can do both. So initially after birth, the pulmonary vascular resistance is high, systemic vascular resistance is high, and therefore you get a reasonable balance between the 2. However, as the pulmonary vascular resistance falls, you will get more blood going to the lungs and less blood going around the body. The more blood that goes to the lungs, the less goes to the body, and you get a patient who is breathless with hepatomegaly as they have high pulmonary blood flow, but with low systemic blood flow, and therefore low systemic perfusion. So just again briefly looking at what we call QPQS, or the ratio of pulmonary to systemic blood flow, and we do this particularly in the hyperplast as a sort of like a surrogate, and this is the equation for calculating QPQS, and basically you look at what goes in and what comes out of each of the pulmonary and the systemic circulation and then put that in as a ratio. And in a child with a single ventricle, you can make quite a lot of assumptions. The systemic saturations, the pulmonary artery saturations are the same. They're what you're measuring on your finger probe. The mixed venous saturation should be 60, 70. You may even have a measured one. And the pulmonary venous sats in the absence of lung pathology should be 100. So if you put those numbers in with someone whose finger probe sats are 90%, that means they have a ratio of 3 times as much blood going to their lungs as their body. However, if the saturations are 80%, the ratio is 1:1, which is perfect. And that's how we derive this range of 75 to 85% as an ideal target range for patients after the Norwood or after the arterial shunt. So that just sort of shows you mathematically why the number is 80. I'd always sort of in my head thought 1:1 means sat should be 100, but actually 1:1, if you've got common mixing saturations, that's a saturation of 80%. So if you are thinking about using oxygen in patients with hyperplastic left heart syndrome or other patients after arterial shunts or the Norwood, you have to be very judicious. So oxygen is a patent pulmonary vasodilator. It reduces the pulmonary vascular resistance, which increases the pulmonary blood flow, so you get high saturations, and reduces your systemic blood flow, therefore reducing your perfusion. So in these patients, we would advocate nasal cannulae with those little neonatal low flow monitors to titrate sats to 75 to 85%. I don't like wafted oxygen because you've got no idea how much the baby is getting. and you have to have very careful monitoring to stop oxygen as soon as the saturations are in range. And all babies that, you know, if you do see a baby coming into A&E or somewhere, their parents will usually know exactly what their target saturation range is, and if in doubt, you can always call the cardiac centre, and parents may also have a copy of the clinic letter too. So now just coming on to the last one, which I think probably most of you will guess the diagnosis by exclusion, but a 37-weeker meconium at delivery, intubated, ventilated, oscillated, oxygenation index of about 40, reduced colour and perfusion, no murmur audible, 4 centimetres liver, and the arm and leg sats are 60%. So putting to one side the obvious sort of meconium aspiration, PPHN, respiratory causes, what cardiac picture do you think could be the cause here? So it's like, who's going to be the brave person to write the first thing, and then everyone else can say.
You have to hold out for the answers. It's oh, there we are.
There we go. So yeah. So I think also, you know, it's a little bit obvious when you're doing a talk about neonatal cardiology that TAPVD is going to be in there somewhere. But this really is the sort of, you know, the classic picture of an obstructed TAPVD. So this picture is of course obstructed TAPVD, and it's important to remember that TAPVD can present actually at any age, and we have children who are much older presenting with TAPVD as well if it remains unobstructed. So in TAPVD, the pulmonary veins come back together to a confluence and then may drain down a descending vein into a hepatic vein, the ductus venosus or the IVC. They may drain via an ascending vein to the innominate vein or the SVC, or they may drain within the heart, so say somewhere like the coronary sinus, or they may actually drain in a mixed type pattern. And this echo here just shows with the scales down, pulmonary venous confluence, and watch as it descends, and comes down in this descending vessel, and then just drops into one of the hepatic veins. And the scales are turned down quite low, so you can see the flow because it's low flow, but you can see it really gets quite turbulent, the flow, once you get down into this area here. And the important thing to remember with obstructed TAPVD is all forms can be obstructed. And actually, some of the sickest kids I've seen have been obstructed supracardiac TAPVD, not infracardiac TAPVD. And someone's just said, could this not be severe PPHN? Yes, of course, it definitely could be severe PPHN. And in fact, the majority of the TAPVDs are diagnosed because an echo is performed looking for PPHN, or they come over for ECMO, and actually the TAPVD diagnosis is made on echocardiography at that point in time. So embryologically, the pulmonary veins form as a confluence that should attach to the left atrium and this membrane break down. And so in TAPVD, that's been a failure for that to happen. So these babies, if you're talking about obstructed TAPVD, will often present pretty soon after birth with cyanosis very well and needing immediate or rapid ventilatory support. They usually require ventilation as you're unable to oxygenate, and they may need high oxygenation indices. And they often have poor systemic perfusion as all the blood is basically stuck in the lungs and can't get out of the lungs. In terms of oximetry, if you've got low systemic perfusion, you're going to have low blood pressures. And if you've got blood stuck in the lungs, congested lungs, inadequate mixing, then you're going to have low saturations. And the points at which things can obstruct is not the diaphragm, but into the vessels that it's draining in. But also you must have an atrial communication to be alive with this condition. And if the atrial communication becomes restricted, then that is another point of obstruction. And this has a more typical chest X-ray. You've got the supracardiac snowman in a snowstorm, etc., etc. Generally speaking, you've got pretty plethoric looking lung fields that look congested. And the unfortunate thing is that the chest X-ray differential often is very much the same kind of picture on X-rays you might get from meconium aspiration. So it can be very tricky to differentiate. The ECG, often you have a right dominant circulation, so the ECG may look normal. So in summary, these kids are often very sick initially. Prostin may well make things worse. So prostin is a pulmonary vasodilator, and then you also increase pulmonary blood flow potentially with the duct as well, and therefore you might get more blood pouring into the lungs that can't get out. If you have pulmonary congestion, you have difficult ventilation, you have low return to the left heart, and therefore low systemic blood pressure and perfusion. You have obligatory right to left shunt, and the desaturator is therefore unresponsive to oxygen, and the chest X-ray will look extremely congested. So just a point about Prostin and TAPVD. The jury still is a bit out on this. There are some theories that if the ductus venosus is where the veins are draining, then Prostin might help relax the ductus venosus. However, there are still sort of concerns about pulmonary blood flow being increased in the presence of a duct. I think often over the phone it's very difficult to make the exact diagnosis, and therefore it's sometimes we will advocate just start Prostin and then it can be stopped as soon as the kid's had an echo. However, maybe if the kid was coming from, say, Bellsham just down the road and we thought it was probably TAPVD, we may well say don't start Prostin, just get the kid here and we'll work it out when they get here. But if we're retrieving someone from the south coast, then it may well be safer just to have a dose of Prostin on. The reason I'm a bit cautious is I've seen a couple of kids who've been started on Prostin, and then the Prostin has been rapidly ramped up to doses of 100 or 200 because there's been no improvement in the child. And the reason there was no improvement in the child was the Prostin was making the child progressively worse. But I think if you're talking about putting Prostin on at 5 or 10, that's a bit different than ramping it up to those high numbers. So I think, you know, again, we can say if anyone else has got anything to add in terms of management that they would do. But I think pretty much it's all exactly the same. It's get the child out of there in as safe a way as possible. And someone's just asked about hyperoxia tests. So I've never really asked anyone to do a formal hyperoxia test, but usually what we would say is maybe give a trial of oxygen. So just give the child some oxygen and see what happens. So particularly if you've got quite a well kid that's come in, maybe a 6-week-old baby that's come in with, say, bronchiolitis and desaturated, and put them in a high amount of oxygen and see what happens to their saturations. If they come up to 100 very quickly, then it's probably just bronchiolitis, and if they don't, then it may well be cardiac. And the same, but to be honest, the majority of kids that refer to us with TAPVD, they're referred to us already in 100% oxygen on nitric, so they've already sort of had the hyperoxia test. But I must say I've never done one where I've got people to do arterial gases on and off. So I think it might be something that maybe paediatricians do more than cardiologists ask for, if you see what I mean. Normally the history and the saturations are enough for me. But I think it does also probably depend on your cardiac centre. We're not kind of big on doing that. Someone's asking about what dose of Prostin. It kind of depends on the age of the kid and the situation. If it's a patient that's presenting relatively well, that's maybe relatively young, so just a couple of days, then I might start, say, 5 or 10. Anything below 20, you're usually safe to avoid intubation. But if you're having to use more than that, then you may need to intubate. So you've got to think about what the facilities are for intubation and whether the child may destabilise with intubation. So if you've got a child that's presenting, say, 7 days of age, completely clapped out with no femoral pulses, you may actually want to intubate the child and put them on a higher dose of Prostin. How would you know this baby is not a TGA? Agree, this baby could well be a TGA. You would not expect the chest X-ray to look like that in a TGA unless the TGA also had meconium aspiration, which is of course possible. And we've certainly had a baby with pulmonary atresia referred for respiratory ECMO that turned out to have pulmonary atresia, but had coexisting meconium aspiration, which is what gave the chest X-ray appearances, but the desaturation was actually due to the pulmonary atresia. So I'll just finish these slides. So we've talked about that. Just talk briefly about cardiomyopathies. So these can present at any age. Fetally, the heart has lower loading conditions, so poor function on antenatal scans is usually a very bad sign and will usually get much worse postnatally. So if you have a patient that's delivering where antenatally there's been a detection of poor function, you've really got to worry about this kid's prognosis. Presentation at birth of any cardiomyopathy is concerning. In terms of dilated cardiomyopathies, think about fetal myocarditis. Is there any history of maternal illness, and particularly in the later gestation? We've had babies presenting with congenital enterovirus myocarditis where the heart was within a week was calcified on chest x-ray. Metabolic conditions may be presenting genetic, and potentially a tachymyopathy, so patients that's had an in utero tachycardia. Hypertrophic, this is usually very bad if presenting at this stage, and you've got to think about things like Noonan syndrome, HOCM, which would be exceptionally bad at presenting at this age, and metabolic. And restrictive cardiomyopathy is just catastrophic, whatever age, because really the only treatment is transplant. So if you're a neonate, that's particularly bad. Arrhythmias. Antenatal arrhythmias undetected could lead to poor function and hydrops, and that's tachyarrhythmias and bradyarrhythmias. Complete heart block can be seen in maternal anterolar or left atrial isomerism. If it's in the context of left atrial isomerism, the prognosis is extremely poor. For some parents, the fetal heart block is the presentation of their lupus, so they may not have a previous diagnosis. Some neonates can present in utero in flutter or immediately after birth, and it's important to know that the fetal or neonatal atrial rate can be greater than 400. So a 2-to-1 block will not necessarily have a heart rate of 150 per minute as you would usually expect in an older child or an adult. The good thing with flutter is usually it just needs a shock, and then they're totally fixed. We often put them on a bit of a beta blocker, as some of these kids with flutter will also have an accessory pathway. SVT management is as per APLS guideline, so a shock if they're shocked, otherwise give some adenosine to get a diagnosis. In terms of complete heart block, what we usually do is just observe the baby. If there's no signs of hydrops and the baby is well, then the baby will go home with close monitoring, and a lot of these kids won't end up with a pacemaker until they're 16. If, however, the baby is compromised or the heart rate is persistently below 50, they may need isoprenaline or temporary pacing. And indications for pacing prior to discharge include pauses, low heart rate variability, or heart rate persistently below 50. Neonates presenting with VT, you've got to worry that there might be some tumour, and this is VT as in a sort of more malignant VT, as opposed to the baby VT, which is a finding that can be an incidental finding of a broadish, complex, slow VT in a very well baby. So in summary, always get help ABC. It's usually prostin to maintain a duct 5 to 10, to open a duct 20 up to 100. Senior help, transfer a cardiac centre, and then advanced management based on discussions with the retrieval team and the cardiologist. And it's just important to know that in a lot of places, the cardiologists are cardiologists, they're not intensivists. And so the retrieval team is a very good person to liaise with as well, or the ICU that the baby's going to, particularly for questions about what drugs to intubate and inotropes. Cardiology can advise to a certain extent, but will not necessarily be knowledgeable about all of those things. So, has anyone got any questions? As a cardiologist, do you want an ECG in all babies with a murmur? Ideally, if you have access to it, because it does help us stratify when we would see a baby. If we see a baby who is well with a normal ECG, then we are less worried than if we see a baby who has an abnormal ECG, in which case we would probably aim to see them a lot quicker. But again, appreciate that not all services have the facility to get an ECG done. What conditions are normal antenatal scans less reassuring? It kind of depends. If you're talking about the anomaly scan, nowadays, because the anomaly scan involves many more views than it used to, most main diagnoses should be picked up. You would hope certainly that single ventricle conditions would be picked up on routine anomaly scans, and TGA now should be too, as well as great vessel discrepancy and hence coarctation. But in terms of things which could be missed and then the more common ones to be missed, coarctation of the aorta, because the duct is still open, particularly if the arch is a normal size. TAPVD, as the veins are not always that easy to see. And obviously things like VSDs, small VSDs may well not be seen on a fetal scan, or mild degrees of AS or PS. So it's about sort of putting it into context. If they've had a fetal cardiac scan, then the chances of something being missed are much, much lower. Sharing the slides, yeah, I'll email them to Nick, I've got them as a PDF. Pulse oximetry. So this one's a big point of discussion, and British Congenital Cardiac Association is sort of looking at some guidance on this. The issue that the two schools of thought is, one is that even if it doesn't pick up all congenital heart disease, it picks up babies who have respiratory problems, PPHN, and allows them to get prompt medical treatment. My concern with it is I think it can be falsely reassuring, and that I think it probably should be done, but it should be done with the caveat of things are okay at the moment. If your baby develops any of these signs or symptoms, then you should seek medical advice. And I think it's just the main thing, because there's obviously, it's the same is when you feel the femorals on a 6-hour baby check. Of course they're going to be there because the duct's still going to be open. So it's just very important that people know that things are not perfect, and just because a SATs and blood pressure check is fine doesn't mean that there might not be a problem in the future. HLHS. Okay, so I hate ECGs and electrophysiology. HLHS are very, very common in neonates. In a well child with just a few HLHS and no other clinical signs or concerns, we would probably just say leave the kid alone, maybe repeat the ECG in a few weeks and see how things are. If the ectopics are much more frequent, so you're getting sort of almost bigeminy type picture, or they look multifocal, or maybe there's something not quite right with the child, then I would probably say get a tape and just check there are no runs of atrial tachycardia. But again, it's the sort of the importance of safety netting. But HLHS are very, very common, and the most common thing is that they're in late stage labour. People hear a few ectopic beats, and so the baby gets an ECG at that stage. Explain the saturations difference in closing PDA coarctation. Yeah, I'll just go. Oh no, I don't seem to be able to go out of my slides without closing everything. Oh, there we go. Okay, so while the duct is open, you may get right to left flow. If you've got a very tight coarctation, you will get right to left flow across the duct, even if the patient hasn't got PPHN. And therefore your feet SATs may be lower, but because you've got good ductal flow, your blood pressures will be pretty similar. As the duct begins to close, you will probably start getting a drop in your blood pressure in your leg as the ductal flow is less good, and your saturations will probably begin to come up as you'll have less right to left flow. And then finally, once the duct is shut, the only blood going to your feet is going to be oxygenated blood, so your saturations will be normal, but you'll have a marked upper limb, lower limb blood pressure differential. Obviously, this is pretty textbook, and not all babies read the textbook, behave like a textbook, but if you have this pattern, not all babies with coarctation will have low feet SATs. And so that is why if you've got a milder coarctation, it could be missed on the pulse oximetry screening. And any other questions? Ooh, recommend textbook online resources for congenital heart disease. I don't know actually. I can't remember which hospital it is. One of the American hospitals has I think it is, yeah, Cincinnati, there we go. Cincinnati has got a very good website and lots of information about all the different individual lesions. In terms of textbooks, the majority of congenital heart disease textbooks are pretty hardcore, so they're sort of full-on congenital heart disease, and are about like 300 quid per book or whatever. So I must say I did most of mine looking at stuff online, and I think there's one that's, I think it's Park, and there is also, yeah, there we go, My Long Park Textbook of Pediatric Cardiology. That's it. That's one that I've seen quite a few people have, and there are some other ones that are sort of around, particularly sort of nursing books, Guide for CICU Nurses, that cover the lesions quite nicely. But I think online now there's quite a lot of resources. Yep, CHD, so it's just under 1 in 100, but remember that includes tiny muscular VSDs as well. So actually, it's you know, the one at just under 1 in 100 is not critical congenital heart disease. And in terms of textbooks as well, I forgot that watch this space. There will soon be an Oxford handbook of congenital heart disease, which we're trying to do at the moment. So that will be 1 page on each of the lesions in this a similar kind of format to this, hopefully. Have I got any other questions or thoughts? And in terms of other sessions, I'm working from home at the moment, so I can do more sessions. So maybe if you contact Nick with if there's anything in particular you want to know. Will is going to do ECG. Don't ask me to do ECG because you won't want me teaching ECGs. So will be doing ECGs, but if there's any particular lesions or other aspects, then maybe let Nick know, and then I can try and put something together and talk.
Fantastic, thank you, Hannah. And please, everyone listening in, also, could I ask you all to turn to the people in your own hospitals and ask them to teach as well? Get them to drop me a line. That would be lovely. Thank you.
I think someone's just, 6:30 tonight is Will's ECG teaching. Cool. Okay. So I stop recording now, and then